Thank you all for joining us. You heard what the senator had to say. Any reaction?
I think what he talked about in his proposal and the other proposals that are out there is really remarkable in the sense that there's a great discussion going on in the country about affordability and coverage, which is taking on different forms. There are a lot of different proposals that are out there, but what's kind of interesting and new is that it's focusing more attention on Medicare, which is what we're here to talk about today. Many of these proposals are called Medicare for someone, Medicare Part E, Medicare Choice, Medicare for All, Medicare Buy-in. And what that's done is allowed people to take a look at Medicare. Medicare is very popular. I think everybody in this room knows that. But Medicare also faces some real challenges. And at this point in the debate, people are starting to look at Medicare and go, what's next?
Zirui?
Well, one of the areas that the senator touched on, which I think resonates with many of the bills currently under discussion, is that we should start with the foundation of what does the patient value. And when we talk about policy, often we come at it from an economic perspective or a political philosophy perspective, but I think it helps in health policy to start from the question of what do patients truly care about? Mm-hmm. And when I'm in clinic or practicing in the hospital, I've generally found that patients care about a few key things.
Such as?
They care about availability, meaning access, the ability to obtain care when it's needed, having a person or a hospital or a medical home there to care for them when the time comes. They also care about choice, and choice is also part of availability. But then, as Tricia noted, they care a lot about affordability, the ability to pay for care out of pocket and hopefully to pay less going forward, given how pressing out-of-pocket costs have been to individuals and families. But beyond these two simple principles, patients also care a lot about the ability of the healthcare system to deliver high-quality care, and something that is very difficult to legislate per se, which is the trust between a doctor and a patient.
Let me go to Fred. Fred, do you have any thoughts on what the senator said? And I know your organization, one of the things you have is a helpline.
Yeah.
And you hear from more than 20,000 beneficiaries a year. So what's your reaction, and what are they telling you that they are most concerned about right now?
Yeah, it's very similar to what Zirui had just mentioned in terms of the issues that we're tracking and hear about. And so people are calling us and clamoring to get into Medicare. So as they're approaching age 65, they're needing to access that coverage, and they trying to understand their options. And also we have a number of phone calls from people who are very concerned about access to prescription drugs and health services through private Medicare plans. And lastly, the issue of affordability keeps coming up. People of all incomes and educational backgrounds are surprised at some of the cost sharing that's in the Medicare program. And so what we really try to do is we make resources available to individuals to help navigate their coverage so they can understand best how to meet their individual circumstances. And so these are also very top trends that we're seeing on the helpline too.
Tricia, I know complexity, as Fred mentioned, is something that so many beneficiaries wrestle with. I think there are more than 24 plans to choose from. Whose job is it really is there a way we can reduce that complexity, and whose job is it to do that?
That's a great question. So when I first started working in Medicare, it's pretty easy. You turned 65, you went on Medicare, everything was automatic. But now that Social Security and Medicare are no longer tied to the hip because the full retirement age for Social Security is rising, people turn 65, there are more decisions to make, including whether to sign up for Part B if you're still working. So things have gotten a little bit complex. And then there's the issue of Medicare Advantage. There are dozens of Medicare Advantage plans available to people across the country, on average something like 2 dozen. And they're standalone drug plans, again, like 27 plans per person. So I don't know how many people in this room have tried to help somebody sign up for a plan. It's really hard.
I was surprised. My husband and I were reading the Wall Street Journal, a little blurb about the SHIP programs that exist apparently in every state to help people navigate this system. And so I went on Medicare.gov to look it up. Where does it say, you can go to the SHIP program in your state and they'll help you? it was impossible to find.
Ships are hard to find. I'll turn it to you in a second since you know this so well.
Yeah.
Ships are hard to find.
Yeah.
You know, explain to people who may not know what they
These
do.
are state health insurance counseling programs. They're wonderful. They're staffed mostly by volunteers. They're fantastic. But not everybody knows about them. They're difficult to find, and you go there for some reasons. You go to Medicaid offices to sign up for low-income programs. You go to Social Security to sign up for Medicare. It's a little bit difficult, and you go to the website to sign up for plans and to choose among them. And a lot of people find that stressful. We find that people sign up once, they never revisit their options, they don't switch plans, which makes me think that the marketplace isn't working as people intend, where you compare your options each year. And
So
choose the best
even
one.
if their drug prices go up, even if their doctor is no longer included, they won't switch?
I mean, our focus groups people say it's just so hard. They sort of stick with what they know because they're not sure they can choose something better, and it's just difficult.
Yeah, we try to caution individuals not to, become paralyzed in terms of making those decisions. So it's really important that the tools that are available to beneficiaries reflect the reality of the prescription drug plans and Medicare Advantage plans, in particular with Medicare's Plan Finder tool. We're hoping that it's improved where you can look up the networks of providers that are available in the Medicare Advantage plans and also have more easily tailored information around the pricing of drugs and the tiers and the pharmacy networks. And as Tricia had mentioned earlier, a top trend that we've been hearing on the helpline around Part B enrollment are people are missing, turning 65 and they're missing their initial enrollment period to enroll into Medicare, and then they're facing lifetime Part B penalties and gaps in coverage. And earlier, Kathleen, you had mentioned what can we do now to improve the Medicare program, and I'm thrilled to mention that the last week the Bennies Act was introduced. This is a bipartisan bill that will eliminate these punitive gaps in coverage and also improve beneficiary communication and notice around when to enroll into Medicare. We've helped hundreds of individuals try to understand how to best enroll into Medicare, and then also we're just hearing stories of individuals who've been paying very high COBRA premiums and find themselves locked out of the Medicare program. And so this piece of legislation will be able to address that.
Zirui, I'm wondering what role physicians can play in helping Medicare beneficiaries with some of these issues that they call Fred's organization to discuss, things like high prescription drug costs or even denial of benefits.
That's a wonderful question, Kathleen. I believe that physicians can help patients be better consumers in the marketplace. We, as a nation, as a healthcare system, put the patients in many positions of being a consumer. And we expect, through the right incentives or policy initiatives, to encourage patients to shop effectively, to choose among options in a way that is ideal to them, to make an optimal choice among a choice set. Yet evidence has shown, and many studies over the years have clearly demonstrated, that patients on average are not able to shop effectively for healthcare as much as we would like them to do as policymakers, as designers of health policies. So an area where physicians and health systems can really play a role is helping the patient navigate this incredibly complicated system, and at certain points along the way, such as where are they in their deductible, what drugs are higher copays versus lower copays, or what services are higher value versus lower value at a point in care in their trajectory of care. These are key places along the patient's journey where a physician or health system or medical home can help the patient become a more effective consumer in our currently established healthcare system.
Since we're on this point, touching on drug pricing, would anyone like to react to the announcement by HHS Secretary Azar about this finalization of the requirement that now the actual price of a drug be included in commercials? How important is this?
So Kathleen, we're supportive of steps of greater transparency with drug pricing, but in effect for people with Medicare, knowing the overall cost of the drug doesn't really necessarily help them make decisions. As Zirui had just mentioned, people are navigating multiple plans and multiple formularies, and what we're seeing is that the onus is really falling on the beneficiary and the pharmacist and the physician to help people access their drugs, because the information isn't necessarily readily available to them to understand if the drug is covered on the formulary. Must they try another drug before this drug is covered? So we're seeing people going to the pharmacy and leaving the pharmacy without their prescriptions. And so there are some administrative reforms that are just common sense reforms in terms of modernizing the Part D appeals process to help people understand if they're unable to purchase a medication, why the reason was denied, and this would help physicians and beneficiaries access their drugs. In particular, with the Medicare Advantage program, a recent report that was released stresses that when people do appeal for their drug coverage or their health service coverage, if they appeal, they have a 75% chance of winning that appeal at the second level. So we're really supportive of the appeals process, and we have a number of reforms that we'd like to see enacted.
Tricia, any thoughts on the announcement?
Well, I think it's hard because, as Fred was saying, when you see a price in a TV ad, you don't really know what that means for you.
Right, that's what Senator Merkley was saying. Is it my price? Is it what my health plan is paying?
What you care about is what you are going to pay. That's what the patient cares about. There is another proposal that I found intriguing, which would somehow create technology that gives physicians real-time information so that physicians know when they're prescribing whether the drug that they're prescribing is on the plan, is covered by the plan, whether it's on a preferred tier or not, and what their patient would have to pay. Because if they sort of say, I happen to like this drug, I think it'll work, and they see it's not covered, then on the spot they can say, oh, wait a minute, I see it's not covered, here's an alternative, similar drug, it'll work just fine, you should go with that. I think making it easy for physicians and making it easier for patients is really a direction where Medicare needs to go if Medicare is going to continue to be such a market-driven environment in terms of plan choice.
How concerned are all of you right now about what Medicare trustees are predicting, that the program will be insolvent in 7 years? And do you have any thoughts on how we preserve it, keep it going? Now, again, do we raise the age of eligibility? 65 to 67.
So I agree with the senator earlier that I think that increasing the age limit is a terrible idea. And as I mentioned earlier, many people are just waiting to enroll into the Medicare program because either the health insurance they have is unaffordable or they've been without coverage for a period of time. This program is strong and built to last in the sense that the Affordable Care Act had extended out the Part A trust fund, and now as a result of the recent tax legislation, this recent news has come out. But I think there's multiple approaches and savings, and it's really important to mention too that both the prescription drug programs and the Part B are funded through revenue and beneficiary premiums too, and so those programs are stable.
No, sorry. Go ahead.
I think there's a very interesting way of thinking about your question, which is how do we handle this issue of healthcare spending growth? Spending in healthcare and other sectors of our economy has always been the product of the prices of services times the quantities of services. So if you want to do something about spending, if you want to touch spending, you either have to touch prices or quantities. And in our healthcare system, there are only two ways to touch prices. The two mechanisms are either competition or regulation. And so the government has an incredibly important role in both avenues of touching prices, but it can also affect quantities in a number of ways. However, if it's difficult to affect the total growth of healthcare spending through either prices or quantities, then the federal government or any insurer could try to affect spending growth through actually capitating or globally budgeting our system of care. And that, as you've seen in recent years, has been a growing trend among payers, both public and private, to use alternative payment models such as bundled payments, global payments, and budgeted avenues of paying for healthcare for a population over a defined period of time rather than on a fee-for-service basis.
The Trump administration, speaking about regulation, they are testing something out, and it really would impact physicians. So I'd love your thoughts on it. And that's moving away, and this is just an experimental program from the fee-for-service program to where you would pay physicians a flat monthly fee. They are hoping this will cut down on the incentive to overprescribe, to overtreat. What do you think?
Well, I think the general notion of moving away from fee-for-service is a good one. We've had many decades of evidence showing that the fee-for-service system is related to all sorts of over-provision or over-utilization. And often that provision or utilization in excess is on average lower value for the patient and for our society as a whole. However, the best way to move away from fee-for-service is still an open question. Is it paying a flat rate? Is it paying providers a salary? Is it paying providers for episodes of care defined on a 3-month or 6-month basis? Or is it truly paying for a population of defined beneficiaries or patients using a budget over many years? There are still competing ideas and lots of important studies to be done to figure out what exactly is the right avenue or right path to depart from fee-for-service. And I don't think that that's a closed issue at the moment.
Tricia.
I do think there's some really exciting opportunities out there, but they're relatively small right now. So for example, there's a program called Independence at Home. And that is a program that targets frail seniors living at home. The goal is to keep them out of the hospital. Well, that's kind of a remarkable idea, and it's had great signs of success, but it's small and it's difficult, and it sort of takes angel docs who want to do this kind of thing because they're going into homes with their equipment and they're doing wonderful things to keep people out of the hospital. There's also a program that's looking at nursing home patients, and we've done some work on this. There are people who are living in nursing homes who are in and out of the hospital. They sort of can't stay out of the ambulance because when they fall, they go to the hospital, they come back, they're more disoriented, their medications have changed, they're high spenders in the Medicare program. To me, this seems like such a good opportunity to improve care, lower costs, help patients, and reduce the growth in Medicare spending. So there are opportunities, but I think we have to be really careful about the incentives that we put into the system so that patients can still see the doctors they prefer, and particularly when they're sick, and that's when people care the most about how their healthcare coverage is working.
Right. Any given policy approach on its own may not be the final solution or the best solution. So for example, in terms of price transparency, there have been lots of studies over the years that have shown that simply imposing or creating a system of transparency on prices alone may not change utilization or spending all that much. It may not improve patient choice all that much, but price transparency could be a part of an overall package of solutions that creates the type of system we want to move towards. Similarly, payment reform on its own has been shown to lower spending on claims by about 1% to 3% over the first few years, and to many that may not be a large number. So there may not be a single idea that gets us to where we want to go, but rather a collective of ideas that can also achieve bipartisan support.
And really, that's how the Medicare program has stayed sort of financially sound over the years. Some of you in the room might remember when the Medicare Trust Fund was projected to be insolvent in 2002. And again in 2009. That obviously didn't happen. It's there, people are getting services and they're getting paid for by Medicare. And largely that's due to incremental changes that Congress has made in order to slow the growth in Medicare spending. So it's a complicated healthcare system that we're engaged in with. Sorry for the preposition there. And because it's so complicated, it sort of makes sense to do things incrementally that work, that are sort of safe for people, so that there's a sense that when you enact changes, they can be adopted without adverse events.
Well, let's go to our audience, because I know we have a lot of questions here, and we have our mic runners available. And while you think of your questions, I'll throw out one more of my own. Fred, I was wondering, what's your take, and what would you say most beneficiaries are thinking about some of these things that the Trump administration is trying or is considering implementing, such as what I just mentioned about moving from fee-for-service to a monthly flat payment for doctors, or what they're talking about regarding the rebates that are currently paid to pharmacy benefit managers. They think that could cut costs, but the Congressional Budget Office looked at it and said, well, actually, initially, it's going to boost spending on Medicare and boost what folks have to pay at the pharmacy counter.
Patients want to be able to maintain the relationship with their providers and have that established, trusted relationship where they know that they can access the physicians and the facilities and the hospitals that they need. And we firmly believe that all people with Medicare have the right to voluntarily enroll into the type of Medicare coverage that they prefer, whether that be original Medicare or a Medicare Advantage plan. Medicare Advantage plans are also very popular. We have close to a third of Medicare beneficiaries that are enrolled in them. But it's important that the beneficiary communications and notices are tested with consumers so they can understand them, since there's annual changes that take place every year. And I just I want to mention, in terms of some promising improvements with the Medicare program as a result of the Bipartisan Budget Act, there are some improvements to Medicare Advantage plans for people who have both Medicare and Medicaid. These are the dual special needs plans. So we're going to see some improvements with the appeals and grievance process. Also, states have the options to add additional behavioral health services through Medicaid. And so we're looking forward to that opportunity too. So I think there are multiple options in the Medicare program, original Medicare and Medicare Advantage, and that all people should have access to them and be able to make an informed, independent decision.
Okay, all right. Any questions? If you would, please stand up and identify yourself.
Good morning. I'm John Rother with the National Coalition on Healthcare. I appreciate the terrific discussion so far. But when I think about the future of Medicare, I really think about demographics. Today, the baby boom generation is starting to go past 75, the years when people are dealing with multiple chronic conditions. About 10,000 new people every day past that marker. And the program, to me, needs more dramatic change if it's going to adapt to that new reality that's happening right now.
So your question?
So a question is, how do we move toward primary care as a key strategy to deal with people with multiple chronic conditions?
Well, that's a wonderful question, sir. Thank you for asking that. Currently in our healthcare system, we have 57 million Medicare beneficiaries, and our nation spends over $700 billion per year paying for the entirety of healthcare for this population of 57 million beneficiaries. Going forward, that number will grow, both because of aging and because of policies that may expand access to Medicare. So in our healthcare system, currently, roughly 1/3 of medical providers are primary care physicians. 2/3 are generally specialists. When compared to other countries around the world, that ratio is roughly more like half and half. So there's a part of the answer to your question, which is around the workforce development itself. How do we encourage health systems and training programs to train more and encourage more medical students to think about careers in primary care? But there's also a different part of your answer to your question, which is around the incentives and the financial models for physician reimbursement that we currently have in our healthcare system. Primary care relative to other fields in medicine is generally paid less and has lower levels of prestige and other non-financial elements that might drive trainees one direction or another. So again, it's a multifaceted solution, but with the aging of the population and the expansion of the Medicare beneficiary population, certainly we should think about ways of promoting primary care here in the U.S.
Tricia?
Yeah, I sort of had two responses to your question, John. One was, I think at some point we're going to have a conversation about revenues. There are more people coming on the program. It's just going to be something that has to go on the table. People aren't talking about it now. And that's particularly true with boomers coming onto the program. They're just more bodies. When I think about the other end of the age spectrum, I think about the need for better models of care for people with multiple chronic conditions. I think about incentives for physicians to practice geriatric medicine. They may or may not be geriatricians, but there are an awful lot of people who need their care managed.
Right.
And I also think of the fact that on Medicare, about 30% of all people on Medicare have a cognitive impairment. So we need to think about how to make the system work for people where they are given their needs. And that's not going away.
All right, another question back here.
Good morning. My name is Emily Belowich. I'm also a consultant with Avalier Health. Thank you so much for your discussion this morning. So we're hearing a lot in the news about a transition into digitally based health tools for senior citizens and for Medicare beneficiaries, especially in the rise of baby boomers. There are a number of initiatives that are going on, such as the e-Medicare initiative and other ways in which we're trying to provide tools for digitally based services, but there's actually been limited information kind of in the public sphere about the value of these tools and resources to patients and beneficiaries. So what are some of your thoughts about either concepts or mechanisms that you'd talk to developers or organizations that are putting forth these tools? What are some of the recommendations you'd give based on the value of these services that they provide to patients?
I mean, I think it's crucial that these tools be tested with consumers and to understand what quality measures and information around cost are most valuable and important to people with Medicare. And in particular, I know that over the course of the last year, there have been some tools released, and there's been some mixed results in terms of understanding the value to beneficiaries. In particular, as I mentioned earlier, I think it's crucial. The most common request that we hear from beneficiaries is trying to understand, what physician is in a Medicare Advantage plan network. So I think there needs to be increased transparency around networks and private plans. And in respect to Medicare cost sharing, coinsurance and co-payments, a simplified tool where individuals could understand how much a service would cost. I know that there are some tools available out there, but if you've ever tried to look up a health service, there's multiple services connected with one type of visit, let's say a colonoscopy. So currently, we're really not at a place to be able to predict how much a service may cost a beneficiary.
Well, Fred, Tricia, Zirui, thank you so much for sharing your expertise on what is such a complicated topic. Thank you.
So much.
Thank you.